Hello everyone and welcome to Boundless Dentistry. In this video we'll talk about one of the most important but rare pathologies that affect your face is trigeminal neuralgia. Now in this video we'll talk about everything that is related to trigeminal neuralgia, starting off with the anatomy, then etiology, clinical features, how do we diagnose such patients from suffering from trigeminal neuralgia, then finally we'll talk about the different treatment options that are available to treat such patients. So let's get started. Now let's start this video by briefly talking about the basic anatomy of trigeminal nerve. Trigeminal nerve is the fifth cranial nerve. Now this cranial nerve consists of motor part and a sensory part, and it is the largest cranial nerve. It's the fifth cranial nerve. It has both, it's a mixed nerve. It has a motor and sensory components, and it's the largest cranial nerve. Now trigeminal nerve is further divided into three parts. The first is the V1, which is called as ophthalmic zone. The second part is the maxillary zone, which is the V2, and the third part is mandibular zone, which is V3. Now, as the name suggests, these three divisions supply each specific area of the face. The ophthalmic zone supplies the area around the orbits, the maxillary zone supplies the area around the maxilla, and the mandibular zone supplies the area around the mandible. Now, the origin of the trigeminal nerve is from basically intracranially, and then extracranially it divides into these three parts. Now, let's talk about the most important pathology that affects this trigeminal nerve, that is called as trigeminal neuralgia. Now, trigeminal neuralgia is a pathology in which there is sudden pain that the patient feels around their face, and this pathology is unilateral, that is, it affects one part of your face, either it's left or it's right. Now when the patient suffer pain, the pain is usually severe pain, and it is brief, like from it can last from few seconds to few minutes, and the pain as described by the patient is stabbing. It's like a knife is stabbing in your face directly, and it is so severe. Now the trigeminal neuralgia can affect any part of the trigeminal nerve. It can affect the ophthalmic zone, maxillary zone, or mandibular zone. It can affect any of these three parts. Either it can affect one part, two parts, or even all of these parts. So it can affect any part of the trigeminal nerve. Now, trigeminal neuralgia is classically classified into two components. Now, the first is classical, also called as idiopathic and typical kind of trigeminal neuralgia, and the second part is symptomatic. Now, let's talk about the classical or idiopathic or typical trigeminal neuralgia. In this case, the patient suffer from unilateral pain, which is brief in nature, and it is described by the patients as electric shock-like pain. Moreover, the pain is abrupt in onset. It comes and goes suddenly. There is no time for this pain to occur, and it occurs randomly. It can occur during any part of the day. And this pain is limited to distribution of either one or more branches of trigeminal nerve. On the other hand, the second type is symptomatic trigeminal neuralgia. In this case, the pain is similar to the classical trigeminal neuralgia, but in this case, the pain that is caused by trigeminal neuralgia is known to be originated from some structural lesion that is present in the root of trigeminal nerve. In classical type, there might be some lesion or there might not be some lesion, but in most cases there is no lesion. But in symptomatic trigeminal neuralgia, there is some lesion that is causing trigeminal neuralgia. So these are the two types of trigeminal neuralgia. First we have classical, also called as idiopathic, and typical, and the second type of trigeminal neuralgia is symptomatic trigeminal neuralgia. Moving on, let's talk about the different etiological factors that might cause trigeminal neuralgia. Firstly, there might be some lesion that is compressing the root of trigeminal nerve. Now, the different kind of tumors that might be present. For example, cerebral pontine angle, there might be some tumor present over there. Posterior cranial fossa tumor, schwannomas, meningiomas, some epidermoid cyst, and sometimes there are deformities from osteogenesis imperfecta which can lead to symptoms of trigeminal neuralgia. So these are all of the factors which compress the root of trigeminal nerve, and that can lead to trigeminal neuralgia. Moving on, there are some primary demyelination disorders that are associated with trigeminal neuralgia. Firstly and commonly, we have multiple sclerosis, and secondly, Charcot-Marie-Tooth disease. Now, these are the two primary demyelination disorders that might lead to development of trigeminal neuralgia. Now, at times there are certain disorders. For example, there might be some head and neck cancer, which as the cancer spreads, they might engulf the nerve roots that are present along their roots. So, these infiltrative disorders can also affect the trigeminal nerve, which can lead to the symptoms of trigeminal neuralgia. And sometimes, when all of these factors are not present, there's certain conditions, and trigeminal neuralgia is one of them, in which these disorders are present in families, so they can pass on from one generation to other. So these are the important and common etiological factors that might lead to trigeminal neuralgia. Now, let's talk about some important clinical features that the patient suffering from trigeminal neuralgia might experience. Firstly, trigeminal neuralgia is rare. It's not that common of a disease. Secondly, it can affect adults when they are in middle of their age, around their 30s and 40s, and trigeminal neuralgia is more leaned towards females as compared to males. Now, of the three zones, ophthalmic, maxillary, and mandibular, maxillary division is the most commonly zone of the trigeminal nerve that is affected by trigeminal neuralgia. And on the other hand, ophthalmic division is the rarest of the zones, of the three zones, to lead to trigeminal neuralgia. So maxillary division is the most commonest one, and ophthalmic is the rarest one out of the three. Now, there are certain trigger zones or points and factors which might lead to patients experiencing those trigeminal neuralgia symptoms again. Now, there are certain factors which you should know, and they are shaving, eating, speaking, and touching. And sometimes even when the wind blows over your face, these symptoms might generate. So these are the some factors which the patients have reported, which leads to development of trigeminal neuralgia symptoms. Now, there are certain areas over the face which the patient do report that these areas might trigger the symptom of trigeminal neuralgia. These are cheeks, gums, teeth, lips, and eyes. Now, how do the patients describe as to how the pain is when it comes? So it is described as being severe, stabbing in nature. It can also be electric, burning, shocks, crushing, and exploding pain. These are all the nature of the pains that the patient describes when they're experiencing such symptoms. So all of these nature, they do describe that the pain is really severe in nature. Now, also, and importantly, the pain is unilateral, either on the left side of the face or the right side of the face, and the duration, as the patients report, it's from few seconds to few minutes, and the pain is precipitated by certain trigger zones, as we have discussed right now. Now, an important part of trigeminal neuralgia is to diagnose it as this is trigeminal neuralgia. So this is really important. So how do we diagnose that the patient is suffering from trigeminal neuralgia? Firstly, we take the history of the patient. Now, the most important part of the history is to take the pain history of the patient as to if the pain is bilaterally or unilaterally present, either it's from few seconds or it's lasts really long period of time, and the nature of the pain. So these are the few questions that you do ask the patient when you're taking a history, and if you're suspecting trigeminal neuralgia. Next, clinical examination. Clinical examination consists of all of the clinical features that we've just discussed, and you ask these things from the patient, and you also observe these things, and patients, they lead you towards the diagnosis. And next, we can also perform diagnostic LA blocks, which provide some relief to the patients. CT scan and MRI, these are the two modalities which are reserved when we suspect some structural lesion that might be present, which might lead to trigeminal neuralgia. So these are the five diagnostic modalities that we have, which helps us in reaching a definitive diagnosis of trigeminal neuralgia. Now, talking about the differential diagnosis of trigeminal neuralgia, there are these 6 conditions that mimic features of trigeminal neuralgia. Firstly, there is secondary trigeminal neuralgia. pain of dental origin, like some dental pain is mimicking the pain of trigeminal neuralgia. There might be some extracranial lesion or any pathology that might lead to a doctor suspecting that the patient might be suffering from trigeminal neuralgia. Sometimes neuropathic pain, neurovascular pain, and lastly some psychogenic pain that might mimic trigeminal neuralgia. These differential diagnoses are important so that we can exclude these conditions in order to reach our definitive diagnosis. Now, after we have reached a definitive diagnosis that the patient is suffering from trigeminal neuralgia, now what are the different treatment options that we can offer the patient in order to reach an optimal diagnosis and the patient is pain-free? Because the pain of trigeminal neuralgia is really severe, so the patients want immediate relief from the pain. So we have two treatment options that we might go towards. First is the medical management and the second is surgical management. Now, moreover, we can classify this in further into destructive treatment and non-destructive treatment. Now, destructive treatment consists of some treatment modality that we are leaning towards which might destroy some structures that are present in order to provide some relief to the patient. But non-destructive treatment, on the other hand, there is no destruction but there is some management which helps to relieve the pain of the patients. Firstly, talking about destructive treatment, it consists of radiofrequency rhizotomies, balloon gangliosis, stereotactic radiosurgery, which is gamma knife surgery. But these destructive treatment, because they do destroy some structures, there are certain complications which are associated. Now, these complications are facial numbness, neuroparalytic keratitis, and complex facial pain. These are certain complications which develop when giving destructive treatment. On the other hand, in non-destructive treatment, firstly we have medical management. Now, in medical management, the most commonly given medicine to the patient is carbamazepine. Now, carbamazepine is given in 100 to 200 mg dose, BD that is twice a day, and TDS that is thrice a day. So, this provides relief to most of the patient, up to 75% of the patient. They do have reports that after taking carbamazepine, most of the symptoms have been relieved. And the second non-destructive treatment is microvascular decompression. Now let's talk about further about different treatment options for such patients. Now let's talk about the first surgical treatment option that is available for such patient. It's percutaneous glycerol rhizolysis. Now, what do we mean by this? Now, this treatment option is most commonly indicated for patients who have arterial and venous compression of trigeminal nerve and also in multiple sclerosis patients. So these are the two main indications for using this percutaneous glycerol rhizolysis. Now, what do we do in this treatment option? Firstly, we use absolute alcohol. We can also use phenol, or we can also use phenol and glycerol mixture, and this mixture is injected into the trigeminal system. As you can see in this case, the mixture of glycerol is injected into this space, which is a trigeminal system. Now, we can do this by using Hortel technique. It's a technique in which we perform percutaneous glycerol rhizolysis in order to achieve this treatment option. Now, what is the primary goal of using this treatment option? Basically, it's rhizolysis, that is to destroy the nerve fibers. And when we destroy these nerve fibers, the sensation is interrupted. And when the sensation is interrupted, especially the nociceptive fibers, which are the pain fibers, so when these fibers are interrupted, patients report that their pain is fading away. They do feel relief from such painful sensation. So this is the first treatment option and commonly given treatment option for such patient, which is called as percutaneous glycerol rhizolysis. Moving on towards the second and commonly given treatment option of patients suffering from trigeminal neuralgia is percutaneous balloon compression. Now, this is a minimally invasive procedure now, and the most important and primary goal of performing this percutaneous balloon compression is basically we compress the trigeminal nerve so that the pain receptors, mainly these fibers, their pathway is disrupted, which causes pain. And when these pathway is disrupted, the sensation cannot go further, and when the sensation cannot go further, it helps to relieve pain sensation of the patient. Now, how do we perform this procedure? Firstly, as you can see in this picture, there is a pear-shaped balloon, and this balloon is inflated for around 1 to 7 minutes. This is the compression time. When you compress this, the fibers, they are, for the time being, they are compressed, and when the fibers are compressed, the fibers, they are start to die or they are destroyed. So when they are destroyed, it basically helps to decrease the rate of nerve conduction over here, and this helps to relieve the pain of the patient. So this compression helps in compressing the nerves as they're going here, and it helps to relieve the pain of the patient. So this procedure involves compressing trigeminal nerve to disrupt the pathway that causes pain. So this is the second and commonly given treatment option to the patient, that is percutaneous balloon compression. Next, the third most common treatment option that is given to the patient is radiofrequency thermocoagulation. Now, what do we mean by this terminology? Firstly, it involves the use of radiofrequency. Radiofrequency is used over here. Now, what is the purpose of using radiofrequency over here? The purpose is basically it selectively injures or destroys unmyelinated and poorly myelinated nociceptive fibers, which are the pain fibers. So they destroy such fibers, and similarly, like the previous two treatment options, this helps in decreasing the nerve conduction of nociceptive fibers and eventually decreases the pain of the patient. Now, these radiofrequency, they do not destroy all of the fibers. Some fibers they are spared, and these fibers are heavily myelinated, touch, proprioception, which is the position receptor, and motor function. These proprioception, touch, and motor function fibers, they are spared. They are not damaged. Only the nociceptive fibers are damaged. As you can see, this is the radiofrequency needle, and these needle targets this area, which is the trigeminal nerve's root area. All of these areas are targeted, and the unmyelinated, poorly myelinated nociceptive fibers are damaged. So this helps to relieve the pain of the patient. Now moving on towards the fourth treatment option, surgical treatment option for such patients, is gamma knife radiosurgery. Now this is also a minimally invasive surgery. This involves different intercepting beams of gamma radiation. As you can see, these are the gamma radiation, beams of gamma radiation, which are targeted towards the trigeminal nerve root, and the dose is around 70 to 90 GY, and these dose basically helps to target these nerve fibers, especially the pain nerve fibers, destroys them or injures them partially in order to provide relief to the patient. But the pain relief is not immediate. It takes certain period of time. It can take 2 weeks, 3 weeks, and even 1 month to provide pain relief for such patients. So this is gamma knife radiosurgery. Next, we have microvascular decompression. Now, in microvascular decompression, basically now this is an invasive procedure, and it is a direct surgical intervention. Now, how do we perform this surgery? Retrosigmoid craniectomy performed, as you can see in this diagram. An incision is performed right over here, and the main and the important goal of performing microvascular decompression, basically at times some vessel is compressing the trigeminal nerve area. As you can see, this artery is going over here. It's in close connection with trigeminal nerve. So sometimes this artery can compress trigeminal nerve. So when it compresses, patients do experience trigeminal neuralgia symptoms. So the main goal of performing this procedure is basically we have to create some barrier between this artery and this trigeminal nerve in order to provide relief to the patient. So as you can see in this diagram, between this artery and this trigeminal nerve root, we have placed some sponge. Now this sponge acts as a barrier in order to create some space between this artery and nerve, and now the patient experiences relief from the pain. So this is about microvascular decompression. Now lastly, talking about the last treatment option, which is less preferred and less effective, is peripheral procedure. In peripheral procedure, we can perform peripheral neurectomies, which is basically we damage the peripheral nerve which are present, for example supraorbital, infraorbital, mental nerve, inferior alveolar nerve, long buccal nerve, and sometimes lingual nerve as well, although it's rare, but sometimes lingual nerve as well. So we damage these nerves in order to decrease the pain of the patients. You can also go for cryotherapy, alcohol block, and sometimes streptomycin lidocaine injection, but these are the last treatment options, and these are performed after medical and surgical treatments they have failed. So these are those treatments that are as reserved as last resort. After the first and preferred treatment option they don't work, then we go for these peripheral procedures because they are less effective and less preferred. Now lastly, talking about the different dietary recommendations which are given to the patients who are suffering from trigeminal neuralgia. Firstly, these patients are instructed that they should avoid eating hot, extreme hot and cold food because this might trigger their symptoms. They're also avoided to eat hot sauce and chili sauce. They are not supposed to eat this hot sauce and chili sauce because these triggers the symptoms. They should also avoid eating black pepper, cinnamon and ginger. Now, they're recommended to eat that food which is easily chewable because sometimes when you eat hot food, they might trigger such symptom of trigeminal neuralgia. And lastly, the diet recommendation which are given to such patients is they should have food which is low in fat, high in protein, high and calorie diet. These are the dietary recommendations which are given to the patients which are suffering from trigeminal neuralgia. These basically help them in order to avoid triggering the pain of trigeminal neuralgia. Now, in this video, we talked about everything that is about trigeminal neuralgia, starting from basic anatomy, the introduction of trigeminal neuralgia, different etiological factors, how do we classify trigeminal neuralgia, the clinical features, diagnosis, and then thoroughly we talked about the different treatment options, medical and surgical, which are available for such patients who are suffering from trigeminal neuralgia. And lastly, we talked about the dietary recommendations which are given to the patient who are suffering from trigeminal neuralgia in order to avoid the pain of trigeminal neuralgia. So I hope this video was useful for you, and if you like this video, please like, share, subscribe and press the bell icon. Thank you for watching this video. See you next time.